Good evening, good afternoon, or good morning. Welcome or welcome back to the COVID-19 Vaccine Development and Implementation Workshop 2021. I'm Daniel Kuritzkes from Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. And together with my co-host Anne-Geneviève Marcelin from the Hôpital Salpétrière in Paris, it's a great pleasure to welcome you to this afternoon's program. This slide gives you an at-a-glance view of our program. Yesterday, the first two sessions covered an update on the global vaccine situation as it regards COVID-19 and some critical unknowns. And then in the second session, we talked about vaccine development. The day one enduring materials will be available following the live stream. Today, we're going to talk about what do we know about protection against SARS-CoV-2 infection. And in the final session, now that vaccines have arrived, what are some of the really practical issues around implementation of global vaccine strategy? We really value your feedback on these sessions, so please fill out the session survey at the end of each session and participate in the general workshop evaluation after the event. A certificate of attendance will also be sent by email upon completion of the post-workshop survey. Here are some practical tips about how you can participate in the program. You can submit your questions through the live Q&A widget, which you'll find on your screen. And you can chat and connect with your colleagues through the Meeting Hub. If you need technical assistance, then you can click on the technical support icon. I'd like to acknowledge the sponsorship for this workshop, including our gold level sponsor, Janssen Infectious Diseases and Vaccines, a component of Johnson & Johnson, as well as our principal supporter, Roche. In addition, I'd like to acknowledge those non-commercial entities that have endorsed our program, including IAPAC, Nova Health Institute, ASHM, NATAP, the Erasmus Medical Center, and Pandora. So as I mentioned, session 3 will talk about what we know about protection, and Dr. Marcelin is my co-moderator. I'm going to go ahead and just give you a quick overview of the program for this session and our speakers for today. We'll start with a talk by Larry Corey on what have we shown and what have we yet to show with respect to protection against SARS-CoV-2 infection with the COVID-19 vaccines we have available. Jakob Cramer will speak on how to assess protection against infection and transmission after vaccination. And David Eyre will talk about reinfection and protection immunity after COVID infection. In addition, Sanjat Kanjilal will speak on optimizing diagnostics for post-vaccination surveillance. And Ravi Gupta will talk about adapting diagnostics to emerging viral variants. With that, it's my great pleasure to introduce our first speaker, Dr. Larry Corey, who of course is well known to many of you. Professor Corey is the past president and director of the Fred Hutchinson Cancer Research Center in Seattle, Washington. He is also a professor of vaccine and infectious diseases and medicine and laboratory medicine at the University of Washington and at the Hutch. Dr. Corey is an internationally renowned expert in virology, immunology, and vaccinology. He, of course, is the leader of the HIV Vaccine Trials Network and has taken a key role in directing the work of the COVID-19 vaccine and prevention network. Dr. Corey has received many honors, including being named a member of the U.S. National Academy of Medicine and the American Academy of Sciences. So without further ado, here is Dr. Corey.
It gives me great pleasure today to talk a little bit about what we have and what we have not learned about our current portfolio of COVID-19 vaccines. When you think about vaccines per se, as far as the endpoints, one can think about decreasing acquisition of the infection, decreasing the frequency and severity of the disease, and decreasing sort of the transmission in the community. That sounds outlined a little bit better in this slide. Decreasing protection from acquisition, generally called in the literature VES, means vaccinated persons never develop antibodies to the virus where placebo recipients do, and sort of seroconversion defines that. Vaccinating against disease is that the vaccination reduces the frequency and severity of developing COVID-19, and that is generally called VEP for vaccine efficacy of disease prevention. And then there's the issue of reduced infectiousness, or VEI, where essentially vaccination prevents clinical disease. In other words, you can get, but the virus still infects the nose and can replicate and transmit to others. Now, it may replicate in the nose and not be at a titer to transmit, or it may replicate in the nose and capable of transmitting. So let's think through this. All the vaccines in COVID-19 worldwide, as well as in the Operation Warp Speed portfolio, were designed to see if the vaccine reduced the burden of clinical disease. We were in a pandemic, and what was needed in the epidemic was to reduce the burden of hospitalization and death. We wanted to learn about it quickly, so we made the studies large, but powered to have a disease endpoint that would show efficacy and enroll enough people to evaluate that the vaccine could reduce severe disease, medically complicated disease like hospitalization and requiring oxygenation, having low PO2s as well as ICU and or death. And so when we designed the trials, whether it's Moderna, Pfizer, J&J, the main goal was to evaluate each candidate vaccine with a high veracity for its safety and potential efficacy in reducing COVID-19 disease as an endpoint. All the trials basically had around 30,000 persons. We knew for a 50% efficacy with a 30% lower bound, you needed about 150 disease endpoints. We felt it was really important to enroll the populations at greatest risk in our country, the Black, Latinx, and tribal communities, into each trial, and we were successful in this. And it was essential to evaluate vaccines in the epidemiological setting of persons at greatest risk of complications, including comorbidities, age, and race. And we outlined this in a policy statement very early, wrote this article in April and got published in early May, sort of outlining the principles of what the vaccine trials would be. And when you look at one of these vaccine trials, we enrolled these 30,000 people over a 8-week period of time. You sort of sent them a reminder every week, and if they had signs and symptoms of COVID, they would come to the clinic, they would get a nasal swab. If they were COVID positive, they would be followed up as an endpoint. And when we designed the trials, we sort of expected from beginning to end to reach this 150 endpoints would be overall around 6 months period of time for the entire trial, essentially 24 to 28 weeks. Now, we ended up in an epidemic, and both for the Moderna trial and aspects of the J&J trial, I'll show you that this actually occurred about a month and a half sooner to hit these trial endpoints. This is the timeline of the Moderna trial, and this is the timeline the way we drew it up. Now, the highlight of the Pfizer and the Moderna trial are really here. These are the Kaplan-Meier curves from the publication. This is the vaccine group, and this is the acquisition of symptomatic COVID positive under surveillance disease. And you see this enormous separation in the curves, essentially a 94.5% efficacy. And you see the similar thing in the Moderna trial, where here's after the second dose, again, you see very low rates of symptomatic disease, very high rates in the placebo, and again, a 95% protection. In the Moderna trial, we did accrue a lot of people with severe disease, and there were 30 of them. Most of them were in because they had low PO2s and had severe shortness of breath. A couple of them were in the intensive care unit, but as all 30 were in the placebo group, it's essentially 100% protected against severe disease. And in many respects, the two large trials, which have the same prefusion proline stabilized transcript of the spike, full-length spike, it's pretty remarkable that you used two different vaccines. The formulations as far as the lipid nanoparticles and some of the sort of dampening substances in the RNA are different, but the transcript itself is similar. And you got these two large-scale efficacy trials enrolled, completely independently, gave similar results. So one can feel, I think, pretty comfortable about the veracity of vaccine efficacy VEP. Safety data are well tolerated, and the similarity of the data, that's led to the EUAs and to the national rollout. And I haven't, told you anything new about that. I just want to sort of say that the newest data that has come out has been from the Ad26 vector in the portfolio. We have fully enrolled the chimp ad-ox study, and we'll get that out at the end of February. I think we'll hear an announcement about that. And the protein vaccines, the Novavax protein vaccines, is almost fully enrolled. We'll finish enrollment this weekend, the weekend of Valentine's Day. And the other GSK trimer, prefusion trimer, has taken a little bit of while to manufacture, and that's just actually starting their phase 2 trials this month. Now, we've heard a little bit about the data from the J&J trial. I'm allowed, because this has been presented in South Africa, to at least show the South Africa aspect of this, which is, I think, very important, because all the cases in South Africa had the variant, the South African variant, the V2 variant, the B1.135 variant. I think that's the newest nomenclature. And this graph actually shows the moderate to severe disease against the South African variant was over 58%, and 85% effective in severe disease. So really very significant benefit in severe disease, even in South Africa. And the severe disease was similar in South Africa as it was in the United States and Brazil. So here's a vaccine with the sort of Wuhan strain that has cross protection against severe disease. So let's get to the main body of the talk, which is to talk about populations-based measurements of vaccine efficacy, protection from acquisition. Now, serological assays were done in the Moderna and OWS trials at day 0 and at day 6. You enroll 30,000 people. You're looking for disease. The kind of study you did was not want to bring them back to look for serology very frequently. So that is a little bit problematic in some aspects of COVID, and I'll talk to you about that in a minute. And this issue of, are you, even if you're vaccinated and you get prevented disease, did you get subclinical disease? And if you got subclinical disease and you had the virus in the nose, are you infectious to others? Now, this has been a topic of public interest and a very large number of articles in the press about it. Can COVID-19 stop the spread? Here's why vaccinated people still need to wear a mask. Does the vaccine prevent transmission? Does the vaccine prevent acquisition? The vaccine may not protect you as much as you think, and some other kinds of analyses about this. Now, the study design for looking for asymptomatic infection is really far different from a study design looking at disease. To look for asymptomatic infection, you got to find it asymptomatically. So you have to sample people frequently. Moreover, all the super spreading events and all this, we really do know for a long time that it is the early stages within the first 24, 48 hours that you acquire the infection, and certainly in the first 3 days, even before you're symptomatic, is the highest first days post-acquisition. And we actually know that subclinical transmission accounts for at least 40%, and sometimes in some settings, it's been 60% of all the transmissions. So the study here is to look at this as to, does it prevent colonization of the nose and onward transmission? You need to study essentially the nose, and you need to study the nose essentially daily. You don't have to run them every day, but you need to basically sample every day or every other day. And then one needs to identify the person and then do case contact tracing. So acquisition and shedding is a surrogate marker, but actually transmission, what's the level of sampling of replication, or is there a duration, or is there a titer, is there area under the curve, which defines transmission, and that requires case contact identification and sampling. Now, this becomes incredibly relevant with the variants that have started to emerge. This is a slide of the UK's strains of SARS-CoV-19 since the outbreak, and one sees emerging in October or so a variant that's almost like a point mutation that emanated in a couple places and then has sort of taken over at this point in time. When this slide was made a few weeks ago, it was about 50% of the total variants in the UK. It's now up to 60 or 70%, and is emerging in Europe. And this one called the B11.7, which has multiple mutations in it, fortunately doesn't have the kinds of mutations that are reducing neutralization. But it has increased binding and increased case contact, and we assume, we don't really know, that it's either replicating at a higher titer, replicating for a longer duration, or both. And what a vaccine does against that, as far as subclinical acquisition and transmission, remains to be seen, but it becomes increasingly relevant with these variants. So our thought about that is, how do you study this? And we've come up with a study design and sort of that we're starting to put into the field to take a look at a study in which we actually take a look at whether we can find if a vaccine would reduce subclinical infection and the duration of shedding. So the study design is really one in which we either randomize between vaccine and placebo, or do vaccine with delayed in one group and do an open label non-vaccination, but let's say we're leaning towards a placebo, in which you essentially swab the person daily for essentially a 4-month period of time. That's, let's say, 120 days of swabs. You're really starting to officially account after the period of time of the second dose, which is 1 month. Let's say this is the Moderna vaccine. And one swabs every day. One is looking for acquisition because asymptomatic infection gives low titers that can wane. We're drawing blood frequently, once a month. We're following them daily with a questionnaire, and even sampling them if they're university students twice a week, that they have to be sampled, and with a rapid turnaround time. If any of them are positive, they go into either a case ascertained close contact, or we are actually even taking their roommates and their dorm mates, and if someone is enrolled in the trial, to tell their roommates that they are enrolled, see if we can get their permission to get a blood to see if they're seronegative or seropositive. If you are case contact, one is identified by that, we would draw blood, so you'd know the serological status at this point in time. Was the case contact the source? And then follow the case contact with daily swabs for a 14-day period. If any of those are positive, you also have the viral variant, so you can make this assessment as to, who is acquired, what's the sequence? Did the person in the vaccine study get it first, or did the case contact get it first? And you can adjudicate all this in a blinded way. We're planning to think about doing this at sort of universities. One of the reasons to do that is that's sort of a closed community. They're getting monitored anyway, less stigmatization about being a case contact, sort of looking at university towns where the case contacting will be essentially on campus. It's a little bit more of a closed kind of community. And we would link the transmissions by the type of the contact, the timing of the contact, the length of the contact, but mainly the virology and the serology. If they were seronegative, as the contact was seronegative, developed COVID after the index case, it's clearly a case of transmission, especially if the viruses are linked genetically. and you'd have all that information to adjudication committee, and transmission events would be determined in that way, shape, or form. So that is the goal, to sort of think about, yes, you would come out of this study not only looking at the frequency of asymptomatic acquisition, the duration of shedding with asymptomatic acquisition. If people develop symptomatic disease, we would recognize that. But most importantly, we would look at the ratio of case contact transmission, and was that correlated with the people who have high transmission rates. The optimal thing would be able to show that the vaccine actually decreased the rate of even if you got asymptomatic acquisition, you shed for 1 day versus shedding for many, many days in placebo. And if you shed for 1 day, it would be at a low enough titer so that we see no onward transmission. That would give, that would be a wonderful result. It would indicate, that the ability to worry about going to restaurants and going to movies and wearing masks and everything like that, if everybody's vaccinated, would be a wonderful thing. So we're about to embark upon a study to look at whether the mRNA vaccines with their high antibody titers and high efficacy against disease protection can reduce the ability of SARS-CoV-2 to infect their nose at titers high enough to transmit to others. The study will define if a high proportion of vaccinated persons can still be asymptomatic transmitters of the virus, or the alternative, once vaccinated, one is both personally protected as well as unlikely to be a vector for onward transmission to others. I'd like to thank everybody who's funded these studies, and as my compatriot in a lot of the design of these studies, Mike Cohn and Kathy Newsel, and our funders from Operation Warp Speed and the Division of AIDS. Thank you. Especially Tony Fauci and Francis Collins, who've been great supporters of the transmission study, as well as David Kessler. Thank you.
Well, thank you very much for this excellent overview. So now it's my pleasure to introduce Jakob Cramer, who will speak on how to assess protection against infection and transmission after vaccination. So Dr. Jakob Cramer is working on the CEPI, the Coalition for Epidemic Preparedness Innovation, and he has a very long experience in conducting clinical trials and phase 1, 2, 3 vaccine trials against various infectious diseases such as influenza, rabies, Japanese encephalitis. He is working. He is also working at the Faculty of Medicine, University Medical Center of Hamburg in Germany, and it's a great pleasure to have you today for this talk.
I wish to thank the organizers for inviting me to this webinar today, and I will be speaking on how to assess vaccine efficacy against infection and transmission for vaccines against COVID-19. So in the media, but also in the public discussion, we hear a lot a sentence similar to, we need vaccines to control and eventually end this pandemic. However, if you look at published clinical trial protocols describing advanced stage phase 3 clinical trials, they mostly assess vaccine efficacy against disease rather than infection and transmission. The primary endpoints for phase 3 clinical trials are directed against vaccine efficacy against PCR-confirmed COVID-19 illness of any severity. And they also assess secondary endpoints, vaccine efficacy, for example, against severe disease, meaning hospitalization, death. And we also see evidence accruing against the new SARS-CoV-2 variants. But we haven't heard a whole lot out of ongoing large phase 3 clinical trials on vaccine efficacy against transmission and infection. We also have to separate, when we talk about infection, we have to separate infection from viral shedding, from transmission, which is not necessarily the same. And then we have to take into account our diagnostic tools, because they are also not the same. And some are actually testing infection, of course, but the data on infection cannot directly be generalized to, for example, transmission. So if we test for infection by PCR or point of care tests, then we may generate data on infection per se. And if we do demonstrate very high efficacy against infection, this will likely also mean that such a vaccine will then prevent transmission. But on the other end, if we do not show clear efficacy against infection, for example, based on PCR, which is nothing else but showing the presence of nucleic acids in the sample, not necessarily demonstrating a viable virus. So if we do fail to demonstrate infection, that could still mean that this vaccine is effective against transmission. For example, if this is just indicating, as I said, nucleic acid, but not transmissible live virus. So what does prolonged viral shedding, for example, mean for transmission? Again, viral shedding is the same as PCR positivity. Viral shedding has been included in some of the large phase 3 trials in case trial participants have been confirmed to be infected with coronavirus. Then those are selected for prolonged PCR testing indicating viral shedding. But again, this is just prolonged PCR positivity, which does not necessarily, at least, translate into transmission. So let's have a look at some options to test infection in ongoing or planned phase 3 clinical trials, or of course, observational studies. This applies to both type of investigations. So first of all, we need to understand what is actually ongoing in a natural infection. So where is the virus present? What is the viral load? What does this mean for infectiousness in natural SARS-CoV-2 infection? We know that the vast majority of infected persons is actually asymptomatic and remaining asymptomatic throughout. We learn more and more about infection characteristics across age groups. We know that the transmission can occur among children and adolescents, but they are less, they're at lower risk for symptomatic disease. We also, from those investigations into natural infection, have to learn more about the appropriate sampling. Will we perform, for example, testing in clinical trials based on self-testing, or will we require trial participants to actually show at trial sites to have some professional healthcare worker perform the testing? It is clear that a nasal swab can potentially be done by a layperson, but a pharyngeal swab is quite difficult to do on yourself or on your nearest. This is something that has to be done by trained healthcare professionals. To test for infection, meaning to include asymptomatic infections where you do not have clinical symptoms that trigger certain investigations, you are left with continuous, for example, weekly testing in healthy trial participants. Obviously, given the large size of phase 3 trials that we currently see, 40,000 subjects, this will result in very large numbers of tests, which again have implications for logistics and costs and many other aspects, as I will show in a second. In principle, quantitative RT-PCR has a very good sensitivity and specificity, but as said, capacity might be limited or a limiting factor. And an alternative approach would be an antigen point of care test. However, they have some detection limits. They have a lower sensitivity and specificity. There is a higher risk for false negative results, and this may be insufficient to truly test infection, as point of care test may remain negative, although a specific trial participant is actually infected. but they may still be a good indicator for transmission, because there is some evidence indicating if an antigen point of care test remains negative, that particular person is also at very low risk to pass the virus beyond. Test sensitivity, let's have a brief look into this because it is obviously very relevant. Let's assume that the test sensitivity is 99.9%, so really high, but there's always something that can go wrong even for RT-PCR testing. Let's assume you have a trial of 10,000 subjects and you will have to do weekly PCR testing for over 25 weeks. That will result over time, assuming you have a good compliance with in your trial, that will result in 250,000 PCR tests. And even with the 99.9 sensitivity, this will result in 250 false positive cases, which, depending on the incidence, may even outsize the actual number of true infections. Finally, it is important to assess and investigate into the appropriate and most promising type of specimen, nasopharyngeal swabs, saliva, as well as storage conditions and shipment conditions. Let's have a look at one of the trials. I'm sure many of you will have seen these data which have been published. One of the trials that have actually performed weekly self-swabbing and then followed by RT-PCR testing for asymptomatic infections. This is the trial that was conducted by the Oxford University with the Oxford AstraZeneca vaccine in the United Kingdom. In red, you see data from the asymptomatic testing. So this is the results for the weekly self-swabbing and RT-PCR. And the lower panel is the results that have been published on clinical disease. So where you had an indication or indicative signals and symptoms that you would then that would then trigger test, which are obviously a higher positive predictive value. And this is then what was used for the primary vaccine efficacy objective. But let's have a look at the data. As you know, in this trial, there was a low dose, standard dose regimen tested and a standard dose regimen. And you can see, let's start with the lower panel, that the overall vaccine efficacy against COVID-19 illness was about 74%. It was higher in the low dose, standard dose regimen, but there's also some evidence indicating that the true advantage was actually that the low dose, standard dose was given at a larger interval. So it's probably the prolonged interval that has resulted in this higher vaccine efficacy against disease as compared to the standard dose regimen based on a shorter interval. But on the upper panel in red ink, you can see that the vaccine efficacy against asymptomatic disease was much lower. So what we can learn from this is that efficacy against disease does not necessarily mean that a vaccine also protects against infection. Let's look at an alternative option instead of doing direct virus diagnostics in clinical trials on a weekly basis. Most vaccines are based on the spike glycoprotein, either using the full length or the receptor binding domain of this antigen. So seroconversion to an antigen that is not included in the vaccine is one option to test indirectly infection as well. And since most vaccines are based on the spike glycoprotein, an antigen that is offered for seroconversion is the N protein. However, the N protein is a much smaller protein as compared to the spike glycoprotein and has fewer epitopes. It is a non-neutralizing epitope protein, and it has a shorter half-life, only 60 days. So the antibodies against the protein, that's what's meant. The antibodies against the N protein have a shorter half-life of just 60 days as compared to the 120-60 days observed for the spike glycoprotein. And the advantage of testing seroconversion to the N protein is that you don't have to do this on a weekly basis. So you don't have to do repeat, or you will not generate a comparable number of tests, which has an advantage with respect to false positive results. But you still have to consider the test frequency, accounting for the shorter half-life. And it's probably insufficient to just test at baseline and the end of the study. You will probably have to test more frequently. And in the little table on the right upper side, I'm showing you the test frequency that is being published from these vaccine developers when they released their protocols. So you can see that they actually test much more frequently than just at study start and study end. What is complicating this a little bit further is that there's at least some described cross-reactivity with normal circulating human coronaviruses, which again complicates the interpretation of seroconversion to SARS-CoV-2 N protein further. And it is clear that those vaccine candidates that are based on whole variants, or that actually include the N protein as an additional antigen, this strategy will not work, as the vaccine itself will generate antibodies against the N protein, which does no longer allow the use of this seroconversion test to assess infection or natural infection. So what is additional evidence or evidence beyond clinical trials that we will see or that we will have to look at? We can do modeling based on certain assumptions, and we have had a discussion with Neil Ferguson in London, and I'm quoting some of his comments and observations. So even with a very high coverage of a vaccine that gives a very high efficacy against disease, ongoing transmission can cause very high mortality in the remaining 20% if the vaccine does not prevent transmission. So it is obviously an important factor to have a high rate of transmission, of protection against transmission as well. And even if vaccines do offer a high efficacy against infection and transmission, for example, 90%, then still very high coverage in the general population will be necessary to stop transmission. We hear sometimes that given the R0 that has been described for SARS-CoV-2 transmission, we need a 60 or 70% seropositivity in the population to eventually stop the epidemic curve. However, this is based on the assumption that seropositivity does translate into sterile immunity, so complete protection against infection and transmission. Then you can still have around 40%, 30% of the population seronegative, and the pandemic will still end eventually. However, it is unlikely that vaccines against SARS-CoV-2 infection will provide a sterile protection. And that, in my view, means that the actual seropositivity rate has to be much higher as the 60 or described 60, 70% to really have an effect on transmission beyond the promising evidence we have seen against disease. I would not want to deep dive into statistical considerations with regard to transmission studies, just to mention a few options that we do have and that are currently being discussed and also implemented moving forward. There is studies that can be done based on randomized or observational design. We can perform household transmission studies or small mixing groups. We can do contact studies at individual levels, but we also prepare, and the WHO is discussing trial design based on larger scale population studies, including cluster randomized studies, for example, with a stepped wedge trial design, or cluster observational studies to assess vaccine effect on transmission on a population level. A few additional aspects that I'd like to mention. There is a few countries that have advanced already with vaccination coverage. We are in particular looking at evidence coming out of Israel, where far more than 30% of the population has by now been vaccinated. First data have been released from Israel demonstrating a good efficacy against infection. I'm not entirely clear if this is clearly separating disease and infection based on the reports that I have seen, but at least there is promising data indicating that vaccination does have an effect on transmission as well. So we have to stay tuned. More data will certainly be generated and be released in the near future. Obviously, it's unclear what all this evidence that has been generated last year, where we had a perfect match between circulating virus strains and strains included in the vaccine. We'll have to see how this evidence, including infection and transmission, translates for the new variants that are currently circulating. We have to make sure if we do weekly testing, for example, based on antigen point of care tests, we have to make sure that those tests also cover the newly emerging variants. And we should be doing genomic sequencing in case we have tested someone positively. Is there a role for controlled human infection models? This is being discussed currently. It has been discussed last year. Some of the groups preparing controlled human infection models are now developing GMP-conform infection material covering the newly emerging variants as well. An objective could be mucosal replication, for example, could be infection per se, so positivity post-challenge, but I don't expect that controlled human infection models will be started within the next few months. Obviously, the vaccine effect on infection is also being tested in animal models. I don't want to go into details here today, but there is a lot of evidence, and there's more evidence being generated currently. For example, post-challenge and then transmission from vaccinated animals from one to another. There is models that have been established, but you can obviously also assess viral presence in the upper or lower respiratory tract post-vaccination and then post-challenge. And those data are so far also promising, but it is obviously not entirely clear how far these data can be generalized to the human situation. Let me end this presentation with a few final considerations. The evidence on vaccine efficacy against transmission and infection is obviously very important. This will have a huge impact on public health and vaccine recommendations. But let's be realistic first and be happy that we have demonstrated vaccine efficacy against disease. This is a little bit similar like the influenza situation, where we have been using vaccines for decades, and we have not even made major changes to the vaccine for the Northern Hemisphere, at least since 2009 for the H1N1 component, but we have not prevented seasonal influenza, even without vaccine, even with vaccine rollout. So vaccines, the primary aim for vaccines is to prevent severe disease, to prevent people from hospitalization and death, and that is our primary goal, and we should keep this in mind. Obviously, if beyond vaccine efficacy against disease, we are able to achieve vaccine efficacy against infection transmission as well, that would obviously allow us to replace the non-pharmaceutical interventions like face mask and so on earlier. But even without that effect, vaccines are urgently needed. One has to debate if an intramuscular injection generalizing a systemic immunity will really be suitable to protect across the mucosal membrane against infection in the upper respiratory tract. This, as you know, is not the case, for example, for influenza vaccines. And still, they have an important role in public health. Will vaccines, in particular with incomplete coverage or incomplete protection against infection and transmission, really contribute to the herd immunity and eventually end the pandemic? So if we vaccinate 60% of the population with an incomplete protection against transmission, the true herd immunity, or in other words, the true vaccine coverage to really reach a meaningful herd immunity will probably be much higher, as I alluded earlier. Could vaccines with high vaccine efficacy against symptomatic disease, but incomplete vaccine efficacy against asymptomatic infection, potentially even increase transmission? So if you vaccinate and you transform vaccinated person that would normally have experienced disease, not experience disease based on the vaccine, and remain asymptomatic upon infection, they would not know about their infection and still potentially run around and infect others. So there is, even theoretically at least, the chance that vaccine efficacy against disease without vaccine efficacy against infection and transmission, theoretically even increase transmission. It would obviously still prevent disease depending on vaccination coverage in the population. Can we expect, now moving forward, what can we expect from imperfect match of vaccines and circulating strains? As you know, we have vaccines currently in use that are based on the original variant, but there is more and more new variants emerging and circulating with reduced neutralizing capacity of those vaccines. How will this translate into potential effects against infection transmission? This is also something that still needs to be investigated. How will all of this be then finally translated in public health recommendations and vaccine prioritization? And as I said before, even the use of influenza vaccines for decades so far has not stopped seasonal transmission so far. The COVAX clinical development SWAT team has organized a workshop on transmission and infection on 17th of December, and I'm just putting here the link for anyone who is interested in the full report. And we will also provide future support for vaccine developers on these questions. With that, I thank you very much for your attention, and I'm very happy to take further questions at the Q&A session. Thank you.
Thank you very much, Dr. Cramer, for that incredibly insightful talk. Lots of information, and I'm sure we'll have many questions in the roundtable at the end of this session. It's now my pleasure to introduce our next speaker, Dr. David Eyre from the Big Data Institute at the University of Oxford, who will be speaking to us about reinfection and protective immunity after COVID infection. Dr. Eyre is an associate professor at the University of Oxford's Big Data Institute and an honorary consultant in infectious diseases and microbiology at Oxford University Hospitals. He also received his medical degree and his Doctor of Philosophy at Oxford. His research interests include the use of electronic healthcare data and pathogen sequencing to study the transmission, epidemiology, and management of infections. And he's been a key contributor to developing serologic testing for SARS-CoV-2 in Oxford, as well as large-scale study of SARS-CoV-2 infection among healthcare workers. Dr. Eyre.
Thank you very much for the introduction, and I'm going to talk to you today about protective immunity after SARS-CoV-2 infection. So just by way of background to start with, when we're talking about post-infection immunity, it's worth thinking about what we mean by that. So do we want to think about protection against ever testing positive on a PCR test again, which might be quite a high bar to meet, because actually, even if you're transiently exposed to the virus but don't go on to develop infection, you may well still test PCR positive. Or perhaps more helpfully, do we want to think about protection from symptomatic infection? And that might be absolute protection from any symptoms, or actually some partial protection that results in reduced chance of severe infection or hospitalization, for example. And then the third piece here is really to think about, does post-infection immunity change the chance of onward transmission? And that's clearly got implications for onward control of the pandemic. And then alongside this, thinking about what the underlying mechanisms might be, and given those mechanisms, what surrogates are there that we can measure to get some idea of the level of protection. And then the second thing, just to make as a background point, is that actually there is likely to be widespread post-infection immunity, at least in the short term, because we've now had over 100 million cases of infection described worldwide, with only sporadic reports of reinfection. So I'm going to talk to you about what we've learned from a cohort of healthcare workers in Oxford in the United Kingdom. So we have just over 13,500 staff working in 4 different hospital sites with over 1,000 beds between them. And what we did from towards the end of April onwards was to offer staff serological testing every 2 months, and then to offer them PCR testing every 2 weeks, so that we could both look for antibodies to the virus and then also actually presence of the virus as well. We also, from the end of March, offered in-house staff who were symptomatic testing with PCR, so particularly encouraging staff to come forward if they had new cough, fever or loss of their sense of smell or taste. And for the purposes of the presentation, I'll be presenting data up until the end of November last year. So to give you some idea of what the rates of COVID have been like in our staff, this figure here plots the number of cases that we've seen in staff members per week. In the blue line, we've got staff who are symptomatic. So you can see the spike at the start in the first wave where we introduced symptomatic testing, and then just under a month later, when we introduce asymptomatic testing, we get an initial spike, and then incidence trails off over the summer, and then we get the second wave coming into the autumn here, and you'll see roughly similar numbers there of asymptomatic and symptomatic staff being diagnosed. And broadly, these trends that we're seeing in staff follow what we've seen in the wider community with the 2 waves of the pandemic. The other thing to say is that because we tested staff with antibodies at baseline, we could also pick up a number of staff who were seropositive and reported symptoms that occurred before widespread availability of PCR testing. So in the yellow colour there, you've got staff where, based on their self-reported symptom onset date, we could actually date their infection to before testing was widely available. So actually, the cases starting in staff really from the start of March onwards. So in terms of studying reinfection, what we're able to do is take serological tests that were done largely after the first wave and divide people into those who are seronegative and then those who have evidence of previous infection and are seropositive. And in each group, what we could then do, particularly over the second wave as cases increased, was to look at the incidence of new PCR positive results, both in symptomatic and asymptomatic staff, and then also specifically to look at the number of PCR confirmed symptomatic infections as well. The assays that we used for PCR testing included a whole range of commercial and nationally designed assays. And for serology, we used 2 particular assays. The first was an anti-spike IgG assay that we developed in the University of Oxford using a trimeric spike antigen. And this had a threshold for calling the number of antibodies detected of 8 million, which I'll come back to later. We also looked at anti-nuclear capsid antibodies using the Abbott commercial platform for this. And both of these platforms in a head-to-head evaluation had a specificity of over 98%, with the IgG anti-spike assay having a sensitivity of over 98% as well, and the anti-nuclear capsid test having a sensitivity that was just below that, but certainly well over 90%. How we defined people as seronegative and seropositive was by, for the seronegative individuals, saying that they could only have negative antibody tests, that they were first at risk of infection from the date of their first negative antibody test, and then we followed them either to the end of the study or to their first PCR positive test. For those who were seropositive, we had a window period which we allowed of 60 days from the date of their first positive antibody result until we started following them up, and then we followed them to the end of the study or their next PCR positive test. And we did this irrespective of whether they subsequently seroreverted. So if we were measuring antibodies over time, it was possible for some staff to be positive and then negative, but we considered them to remain in the seropositive group if that happened. And we allow this 60-day window period just to exclude any PCR tests that might occur due to RNA persistence from the original infection. And we also only consider PCR positive tests that are more than 60 days after a previous PCR positive test. And so looking at that, it'll become apparent that it's possible for some staff to move between the groups. So you could start off in the seronegative group and then move to the seropositive group if you were infected during follow-up. In terms of the statistical approach we took, so we had the two outcomes of any PCR positive result and then PCR confirmed symptomatic infection. We used a standard Poisson regression approach to model differences in incidence between the two groups, and we controlled for age, for self-reported gender, and then also because the incidence changed over time and we had different amounts of follow-up over differing periods of incidence, we adjusted for changes in incidence over time overall. In terms of which of the two antibody assays we used for the main analysis, that was the anti-spike assay, and that's because we expected before we started the study this to be most closely correlated with neutralizing activity and therefore protection from infection. But we also then did secondary analyses where we looked at the anti-nuclear capsid antibody or a combination of both antibodies. So here are our results from 12,500 healthcare workers, so the majority of our staff participating. And of those, 1,177 had positive anti-spike antibodies at baseline, so just under 10% there. And then a further 88 seroconverted during the course of the study. So this gave us 1,265 anti-spike positive individuals to follow, and then just over 11,000 anti-spike negative individuals. And of those who were seropositive, around 2/3 recalled prior COVID-like symptoms since the beginning of February 2020, and then just over 1/3 had a PCR confirmed infection previously. And many of those who didn't, it's because their symptoms actually predated the time when PCR testing was widely available. To give you some idea of the study population, these are adults of working age, so a median age of 38 years with an interquartile range there between 29 and 49 years. 3/4 of those involved were female. Similarly, 3/4 were of white ethnicity, 15% Asian and 4% black. And then roles fairly typical of a hospital, as you'd expect. Nurses and healthcare assistants making up the largest group at 35%, doctors at 15%, and then administrative staff just less than that. The rates that people came forward for testing were similar in those who were symptomatic. So although we told staff their antibody results as we went along, we were very clear to say to staff that even if you were known to have positive antibodies or you'd had a previous positive PCR test, we still wanted staff to come back to be tested again if they were unwell. And broadly, we got similar rates of attendance for symptomatic testing now. However, knowing your antibodies did affect whether people wanted to come back for asymptomatic testing, and we had less people coming back for asymptomatic testing when they knew they were seropositive compared to those who were seronegative. And actually, despite offering people testing every 2 weeks or so, actually in reality people came back roughly once every sort of 10 to 13 weeks. However, despite the different rates of attendance, when we looked at this sort of in a sensitivity analysis, actually this doesn't substantially change our results. So what were the results? So we had overall an 89% reduction in PCR positive results if people were anti-spike antibody seropositive. And in this group, we had no symptomatic infections. So in the tables here, you can see this in some more detail. So in the grey table on the left, you can see any PCR positive result with or without symptoms. And you can see that we had 223 individuals, roughly 2% of our seronegative healthcare workers who tested positive, compared to just 2 of our seropositive healthcare workers. So roughly sort of only 10% of the number there. And the rates are at the bottom there per 10,000 days at risk. And then of those who had symptomatic infection that were PCR positive, we had about 1%, just over 1% of our seronegative healthcare workers who tested positive while unwell, compared to none of our seropositive healthcare workers. And this plots out the data over time. So what you've got here on the y-axis is the observed rate of PCR positive results whether symptomatic or asymptomatic, per 10,000 healthcare worker days at risk. In the red line, you've got those who were seronegative, and then the blue line, those who were seropositive. And so you can see we've got cases in the first wave and then the second wave of the pandemic at the right and left, but with a much reduced rate in those who are seropositive. And when we adjust for age, self-reported gender and overall incidence, this comes up with an adjusted incident rate ratio of 0.11, i.e. 89% protection. What about the other antibodies we measured? Well, we got very similar results if we looked by baseline anti-nuclear capsid antibody status or a combination of both antibodies. The only difference is perhaps where we looked at both antibodies together, those who had both detected had more convincing evidence of past infection and less evidence of reinfection. So overall, we had 3 individuals who had potential reinfections, and I'll go through these in a bit more detail now for you. 2 of them had anti-spike antibodies detected at baseline, and then one of them also had anti-nuclear capsid antibodies, and then a third individual had just the anti-nuclear capsid antibodies. So to take you through each one, here's the first. So this individual was seropositive for anti-nuclear capsid antibodies only at baseline. So that's shown as the blue dot in the plot above the dashed blue line. But the purple dot, which represents their anti-spike antibodies, well below the purple line, and so negative. At the top of the plot, you can see a green dot representing a negative PCR enrolment, followed by a positive PCR result around 160 days later. And the CN value there from the Abbott PCR platform, roughly corresponding to a CT value in the low 20s. So convincing evidence that they had COVID at the later time point with a febrile illness at the time, and it may well be that actually the prior positive antibody test was a false positive result. The second individual had convincing evidence of infection at baseline. They had appropriate symptoms, were PCR positive, and then they seroconverted with both antibodies becoming positive, which you can see there at around day 50, with both the blue dot above the dashed blue line and the purple dot above the dashed purple line. And then we followed them over time, and then roughly half a year later, they developed a further PCR positive test while they were completely asymptomatic. But then when we repeated PCR tests 2 and 4 days later, these were actually negative. So this could have been a false positive in our laboratory, or it may represent transient PCR positivity without necessarily infection developing. And then in the third case, although they reported a febrile illness in mid-February, they were seropositive only for anti-spike antibodies when tested in May, and then became PCR positive while asymptomatic, again around half a year later, which was confirmed on repeat testing. So again here, questions about whether the initial antibody result in May that was positive for anti-spike was an appropriate result or not. What you can see on this slide is that we were also able to look not just at whether people were antibody positive or negative, but actually to use the antibody reading that we got as well in a quantitative way. So in the left-hand panel there, we've got the anti-spike reading in millions of units. So 8 million there is the dashed line, which represents a positive result. But what we're plotting here is the modelled estimated daily instance of PCR positive results. And so you can see the blue line actually coming down and showing protection from about 4 million units onwards. And similarly, if we look at the anti-nuclear capsid antibody, again, you can see if 1.4 here is the threshold for a positive result, actually below 1.4, you can see that the risk of a positive PCR result actually going down at lower levels than that. So it may well be the case that there's protection from infection at what might be reported as negative results, but actually where the numeric values are near the threshold, there may be less infection. So what about limitations to this work? Well, the first thing is that, as I've touched upon, that there was voluntary follow-up, and so actually individuals only came back around every 10 to 13 weeks, and so undoubtedly we will have missed some potential PCR positive results in those who were asymptomatic. And we also had reduced asymptomatic screening in those who were seropositive, but when we did a sensitivity analysis to account for this, we didn't see a big change in our results. We just looked at adults of working age. They were predominantly white and predominantly female, so we may be less well able to comment on what protection is like in other groups. And similarly, we also just looked at healthcare workers, and there may be a question about how representative they are of the general population, particularly if the nature of their initial exposure may have been higher than other people experienced. And then we only followed people for around 6 months, and so further studies are needed to understand how long people might be protected for. But actually, this may be quite difficult to do in practice, as quite a few of our, even our seropositive healthcare workers have now been vaccinated. And so it may be difficult to now tease apart how much of the ongoing protection is from vaccination versus previous infection. Just to, as I finished, to highlight a couple of other studies which have done similar work. So the Siren study, a UK-wide study of healthcare workers, where healthcare workers were followed from June into November, and here having actually regular fortnightly PCR and antibody testing. And in contrast to our study, where we just defined prior infection on the basis of antibody, here both PCR testing or antibodies could be used to identify prior infection. And so there were just over 6,500 healthcare workers who had evidence of prior infection, and then 14,000 who had no evidence of prior infection. And then in those two groups, we saw fewer reinfections, just 44 in those with prior infection compared to 318 with PCR positive results. And you can see the number who were symptomatic on the slide. So in the study, what the authors do is to calculate an odds ratio for symptomatic reinfection of 0.08. This is consistent with 92% protection, and then protection against any PCR positive result of 0.17, so 83% protection. And then finally, data here from Newcastle in the UK, where similar cohort of healthcare workers with 11,000 or so who had previous antibody testing and were followed up, and they could be defined as having had infection either on the basis of PCR or antibody tests. And of those who were previously infected, 1,000 of them, none went on to get a further symptomatic PCR confirmed infection in the second wave of the pandemic, compared to just under 3% of those who had no evidence of previous infection. So to conclude, in our cohort, anti-spike and anti-nuclear capsid antibodies were both associated with protection from reinfection for most people for up to at least 6 months. No anti-spike antibody positive individual developed a symptomatic infection. And we also saw this evidence of a quantitative relationship between antibody readings, where those who had readings below thresholds for detection, just below the thresholds, still were relatively protected from PCR positive results. So thank you very much for your attention. I'd like to thank all those who helped run the study, many of whom are listed there, and you can read more about it in our paper. And then finally to thank all of our staff who participated. Thank you.
Thank you very much for this wonderful talk about potential risk of reinfection. It was really, really interesting. So we will move now to the next presentation from Sanjat Kanjilal, who is working at the Brigham and Women's Hospital at the Harvard Medical School in the United States. And he will speak on optimizing diagnostics for post-vaccination surveillance. So Dr. Kanjilal is Associate Medical Director of the Clinical Microbiology of the Brigham and Women's Hospital, and is also an infectious disease physician and course director of the microbiology at the Harvard Medical School. His research interests lie in the use of observational and experimental data to improve the diagnosis and the management of infectious disease. His goal is to integrate accurate and interpretable artificial intelligence decision algorithms into clinical workflows and to use these models on a broader scale to inform public health policy. Thank you very much.
So thank you very much. Today I'll be talking about optimizing diagnostics for post-COVID vaccination surveillance. I have no disclosures. So stopping the COVID-19 pandemic really rests on three fundamental pillars. The first is to reduce opportunities for transmission and lower the burden of exposure when a transmission event occurs. And we achieve this through non-pharmacologic interventions such as masks, social distancing, and hand hygiene. The second pillar is to rapidly identify and separate cases from susceptible hosts, which is done through accurate, inexpensive, non-invasive, rapid, widespread, and frequent testing, which is a goal we've been trying to achieve since the very beginning of the pandemic. The third pillar is to safely and ethically reduce the number of susceptible hosts, which can be achieved through a widespread vaccination campaign, which is of course ongoing right now. And so while all three are necessary to stop the pandemic, I'm going to be focusing on the latter two here and the interactions between them over the next 20 minutes or so. So the roles for diagnostics, in a word, are ever evolving, or two words. In the pre-vaccination era, diagnostics really served two purposes. The first was to screen people for asymptomatic infection and therefore block transmission before it can happen. And secondly, for active case detection to help halt outbreaks, as well as to identify patients for clinical management. And the types of questions that diagnostics in the pre-vaccination era were concerned with included whether this person is infected with SARS-CoV-2. If they are infected, is this person contagious with SARS-CoV-2, or are they in the recovery period and not contagious? Or is this person reinfected after a previous infection, or do they have signs and symptoms of a persistent infection over time? In the post-vaccination era, you still have all the questions associated with the pre-vaccination era, but some additional questions that add some new complexities to it. And these include whether this person mounted an immune response to vaccination. Can I distinguish immunity due to natural infection from that due to the vaccine? And the question I think that's most important is this person protected from infection? And then lastly, similar to the pre-vaccination era, is this person who is infected, are they infected despite being vaccinated? And so the goal here in the post-vaccination era is to really develop high throughput clinical diagnostics that quantitatively measure correlates of protection and can distinguish natural infection from the vaccine response. And we have a paradigm for this in hepatitis B, where on the right, I'm showing the classic hepatitis B serology graphs, where you can see we can measure levels of antigen and various antibodies to different components of the virus and use those levels to identify whether a patient is in early infection, chronic infection, or is in a vaccine-induced immune protective state. And so for a SARS-CoV-2 diagnostic, to identify these correlates of protection, we must identify and utilize a target that either directly blocks virus activity itself or plays a major role in disease pathogenesis, or that target directly correlates with another molecule that blocks pathogenesis. And in addition to that, this target must help differentiate prior infection from vaccination. So how do we identify what that potential target is? And so there's a lot of work that's been done on the role of natural infection and the subsequent immune response, and we can turn to that to try to get some targets to begin with. And so we know now that natural infection raises a very broad humoral and adaptive immune response, and the components of that response include antibodies, memory B cells, CD4 helper T cells, CD8 cytotoxic T cells, as well as memory T cells. And so I will focus first on the antibody response and then spend some time at the end of this talk talking about the T cell response. So we know that antibodies developed during natural infection target the nucleocapsid protein and the receptor binding domain of the spike protein. And on the left here, I'm just showing some data that was published last month, showing the formation of IgG to the receptor binding domain on the top panel or to the nucleocapsid on the bottom panel by week from the onset of infection in a set of human volunteers and human study subjects. And you can see that the response to the RBD arises a little earlier than to the nucleocapsid protein, but then both of them level off over the next 2 to 3 weeks. And we know that vaccines induce a robust response against the spike protein and RBD. So now instead of natural infection, we're targeting just a single component of the virus through the vaccine. And data from human and animal studies suggests that anti-spike receptor binding domain IgG blocks viral entry and is a correlate of protection. So on the left, I'm showing some physical data, biophysical data of the neutralizing antibodies shown in pink here, binding the receptor binding domain at almost exact same site and same conformation where the receptor binding domain binds the human ACE2 receptor on the cell. And this is a study that was published in the Journal of Clinical Microbiology that looked at a group of 120 people who boarded a ship in which an outbreak occurred. And they had pre-boarding serologies to compare to post-outbreak serologies. And you can see that those who had pre-existing neutralizing antibodies to the receptor binding domain were less likely to be infected than those who did not have those pre-existing antibodies. And so while this study is small, it would suggest that having those pre-existing antibodies to the spike protein or the receptor binding domain of the spike protein does confer a level of protection, which is consistent with the animal data, in vitro data, and now we know, of course, the phase 3 vaccine trial, which has shown that vaccine-induced antibodies are effective at preventing infection. So then the question is, why can we not simply measure anti-spike RBD levels to assess protection? And there are a number of reasons for why it's a little bit more challenging than that. And I like to call it as a number is just a number. Without the proper clinical context, it's rather meaningless. And so one of the things that's a big problem is that a wide range of titers and values may be elicited by natural infection or the vaccine. And therefore, just the presence of antibodies alone is insufficient to know whether they are protective or not. And from that same study of 120 people on a ship, I'm showing you some additional data here on the right. The light blue lines indicate the antibody levels among those people who are infected on board at day 0. And you can see most of them are below the limit of detection of the assay. And at day 30, post-outbreak. And what you can see here is that the range of responses ranged from absolutely no change in antibody levels, despite being infected, to very robust responses, and the vast majority of people lying on a continuous spectrum in between. And therefore, it's hard to say what level of antibody engendered by infection would actually be protective if people develop this dynamic range of responses. So that's one reason. The other reason is that the clinical diagnostics that exist right now for detecting anti-spike antibodies use very different methods for identifying them, as well as very different reporting results and different scales for that. And so it's hard to know what a number on one particular assay means when compared to a different assay. And so the two most common assays being used right now for measuring these antibodies are ELISA assays and the chemiluminescent assays, CLIA assays, that are high throughput and used by platforms such as the Roche platform, Diasorin, and Abbott. And so what is really necessary here is to identify a standardized threshold of antibody levels above which an acceptable degree of protection is conferred. And so what I'm showing you on the right is just that, except that it's not in humans. This is animal data from macaques. And so this is a study published late in 2020 showing that animals that were not protected, who are shown here in gray, versus those who were protected, had lower levels of pseudovirus neutralization antibody titers, which I'll talk about in the next slide, as well as lower levels of an actual ELISA titer against the receptor binding domain. And they were able to cleanly differentiate these two groups, or almost cleanly differentiate them, with the threshold value of 53 for the neutralization antibody titer and 100 for this particular ELISA assay. And so this is the kind of data we need to then inform epidemiologic studies such that when we follow people over time and quantitatively measure their antibody levels, we can say people above a certain threshold went on to not develop infection, whereas those who had antibodies below this level were at higher risk for infection. So it's a combination of both in vitro work as well as epidemiologic studies. So just a word on plaque reduction neutralization, because it's a very critical assay that we use to correlate what we see in our clinical diagnostics to actual function. And so it's one of the few assays we use that actually quantifies levels of functional antibody, and it's considered a gold standard diagnostic. The downside of plaque reduction is that it's very labor intensive. It takes a long time to perform these experiments, and it's quite costly. There's an additional aspect in that if we were to use live SARS-CoV-2 virus, there requires a higher level of biosafety when handling such an infectious particle such as that. And so what many labs do is in fact use not SARS-CoV-2 itself, but a pseudovirus that is expressing a recombinant spike protein, and therefore it reduces the amount of safety needed to operate with it. However, it doesn't introduce possible artifact due to the fact that this is not actually naturally occurring virus. And so on the right here, I have a schematic of how this neutralization assays work. So in general, we take serum from a human, heat and activate it, and add it to either live virus or a pseudovirus that expresses the spike protein. And then we add it to a 96-well plate, where each well is coated with human cells in a monolayer at the bottom. And we incubate those together over time. And then after a certain incubation period, we measure something called a cytopathic effect, where if a virus infects a cell, we expect to see changes to that cell suggesting it's been infected. And so if a sample from a human has antibodies that block the ability of the virus to infect a cell, we expect that there should be a reduction in the formation of these plaques relative to a sample with no antibody present. And so the amount, the titer of the human serum that reduces the plaque formation by 50% is the plaque reduction neutralization titer 50, is the marker we use to compare the or assess the presence of human antibodies in the serum. And so correlating results from an ELISA or a chemiluminescent assay to plaque reduction titers is really critical to understand what these numbers from these clinical diagnostics actually mean. But we do know that they can vary significantly depending on what the platform was used to develop the antibody, to report the antibody levels, the isotype of the antibody itself, whether it's IgG, IgM, or IgA, and the time since the infection occurred in the host. And so I'm showing here some data from Dr. Koopman's group that compared titers or values obtained from clinical diagnostics that measure levels of anti-receptor binding domain antibodies to plaque reduction neutralization titers. And so you can see here that correlations range from up to 0.83 for this particular IgG ELISA to down to 0.75 for the diazorin liaison XL chemiluminescent assay. And so this variation adds another level of complexity to the interpretation of these numbers. And it basically means that for any assay a hospital or a lab plans to use, they have to do their own plaque reduction titers to compare and interpret the results put out by the instrument. And furthermore, to be able to compare across instruments, we need to run samples from each of them with the same neutralization assay to quantify the variability across platform. And then, of course, what to do about the variants. So the measurement of these anti-S-RBD levels or titers may not actually reflect the functional activity of the antibodies against these newer variants of concern. And so to overcome this, we require regular surveillance with convalescent plasma and post-vaccination samples at day 0, day 14, and day 42 post-vaccination to assess the neutralization activity using either live SARS-CoV-2 or pseudovirus that contains the variant spike proteins. And as I said in the previous slide, this exercise must be repeated for every clinical diagnostic because every clinical diagnostic will give you a different range of values depending on how the assay is run. Above all, this requires very close coordination between governmental agencies that are involved with public health, diagnostics companies, and hospital or academic labs to work closely together to maintain very close surveillance and stay on top of these emerging variants as they spread throughout the various regions of the world. So I'm going to switch now from humoral or antibody-based immunity to adaptive immunity. And so, as I said before, natural infection and to a lesser extent vaccination raises a broad humoral and adaptive immune response. But we do know that antibody responses are not detectable in all patients, and particularly those with mild infection. Yet the vast majority of these people do just fine. An antibody and virus-specific B cells may wane, but we do know that memory T cells may be long-lasting and result in a memory response much later down the line, even if you cannot measure circulating antibodies. And this has been shown in particular with SARS-CoV-1. And lastly, CD4 and CD8 T cells may contribute to the immune response independent of the B cell response, which we know from decades of immunology work. On the left here, I'm simply showing the waning of neutralization titers in asymptomatic and symptomatic people over time. And so interestingly, the CD4, based on studies that have been done doing mega pools of peptides, SARS-CoV-2 peptides, we know that the CD4 T cell response to natural infection is raised not only to the spike protein, the nucleocapsid protein, but to many other virus proteins, including the membrane protein, as well as a number of non-structural proteins. And interestingly, spike-specific CD4 cells tend to show a T follicular helper cell phenotype, suggesting that they're really responsible for optimizing the antibody response to the virus, indicating how important that is. But that CD4 cells targeting the membrane or the nucleocapsid proteins tend to have more likely a Th1 or Th17 phenotype. And so the humoral and the adaptive immune responses are very tightly linked to one another, and infection itself leads to a very heterogeneous response. Each compartment, which I'm showing here on the left-hand side here as being either an antibody response, memory B cells, CD4 or CD8 virus-specific cells, or IgA, each of these compartments has unique kinetics. In this particular study that came out a couple of weeks ago, this group showed that 64% of people developed antibodies or responses in all 5 compartments at the first month post-infection. But that number dropped to around 43% at 6 to 8 months post-infection. However, 95% of people still develop responses in 3 out of 5 compartments at 6 to 8 months. So it does seem that the immune response is durable over time. However, when they tried to correlate anti-spike RBD IgG titers from ELISA to the presence of memory B cells or CD4 memory T cells, the correlation was very, very poor. And so if we are trying to understand the T cell or B cell memory response, it is not possible really to do that using our clinical diagnostics for antibodies. And so the bigger challenge with assessing the T cell response, which may be very important for SARS-CoV-2, is that the vast majority of assays are currently still in research use only. And while we know a fair amount about the breadth and duration of T cells to natural infection, the same level of characterization is yet to be really reported for vaccine-induced T cell responses. Interestingly, in many of these studies, they took volunteer samples from healthy people pre-pandemic and showed that circulating T cells stimulated by these epitope megapools resulted in SARS-CoV-2 specific responses in up to 60% of healthy people, suggesting that prior infection with endemic coronaviruses can actually lead to cross-protection to SARS-CoV-2. Ultimately, if T cells are going to be assessed for COVID-19 diagnostics, there are a couple of models that we've used for other infections, such as interferon gamma release assays, which have been used for many years for assessing mycobacterium tuberculosis infection. One example would be an ELISpot, for instance, and flow cytometry measures, which can try to identify both CD4 and CD8 T cells, depending on both effector or memory responses. But there's quite a bit of work still left to be done to bring T cell diagnostics to clinical use. So I want to thank you very much. And I want to give a special thanks to Dr. June Liu and Dr. Fabian Lucas and Dr. Manfred Brigel for thoughtful discussion around this topic.
Thank you so much, Sanjat. That was a really terrific talk and really helped put into perspective the utility of different diagnostic tests and how we might apply them as we monitor people going forward in the vaccine era. It's now my pleasure to introduce the final speaker for this session, Dr. Ravi Gupta from the University of Cambridge, who will be speaking on adapting diagnostics to emerging viral variants. Professor Gupta is an infectious diseases clinician with a specific focus on HIV, which is really quite relevant because his HIV interests have included the emergence of drug resistance and their impact on the global rollout of antiretroviral therapy. He's now turned that interest to the emergence of viral variants of SARS-CoV-2. In addition, Dr. Gupta has made major contributions in the study of HIV persistence and was the lead author on the study of the London patient who was the second person to be cured of HIV. So it's a great pleasure to turn this over now to Dr. Gupta.
I'd like to thank the organizers for the invitation to speak to you this afternoon, and my talk is entitled Adapting Viral Diagnostics to New Variants of SARS-CoV-2. Here are my disclosures. So since the beginning of the SARS pandemic, we've noted emergence of variants towards the end of 2020. We now have three main new variants of SARS-CoV-2, the South African, Brazilian, and UK variants, otherwise known as 501Y V1, V2, and V3. These new variants are characterized by the fact that they have multiple mutations in spike, and especially in the receptor binding motif, which is part of the receptor binding domain in the S1 part of the spike protein. And of course, the spike protein is sitting on the outside of the virus and engaging with ACE2. Here you can see a schematic diagram, a ribbon diagram at the bottom, which shows spike receptor binding motif in conjunction with the ACE2 receptor. And you can see that there are three key interacting residues amongst a number of others, but these are the three residues that are found in common in at least two of the emerging variants. You can see position N501 here at the top right. This makes a key contact with ACE2, as does K417 and E484. And these are mutated in the variants to N501Y, E484K, and two different mutations of 417 are observed, K417T and K417N. On the bottom right here, you can see from the Wiesler lab some data on interferometry, where they have measured the binding between the receptor binding domain purified protein and human ACE2. In figure A, you can see the on and off rates at different concentrations of the wild type receptor binding domain. And you can see that there is occupancy for a considerable period of time. At the bottom, you can see what happens when you have an N501Y mutation. The on rate is a little bit slower, but the off rate is also considerably slower. So this translates into greater occupancy time. And that is likely important for this adaptation the virus is making in terms of hanging on for longer to the ACE2 receptor. N501Y is also known to be an escape mutation for certain antibodies that we produce. And therefore, there is an unknown interplay between receptor binding and escape from antibodies. This set of structures is illustrating the different variants that I've been describing. On the left here is 501Y V1, in other words, the UK variant, And you can see here the N501Y on the top in the receptor binding domain, as we've just seen. In addition, other key mutations are in the S1 fragment, the delta 6970 deletion, which you can see there, as well as the Y144 deletion. Now, these are really important because the Y144 is in a known antibody binding site for the 4A8 antibody, and delta 6970 removes 2 amino acids in an exposed loop, potentially leading to increased infectivity based on some data from our lab. The delta 6970 is not known to be an antibody escape mutation. There are a number of other residues mutated, including A570D, and of course the 681, P681H near the furin cleavage site, there you can see in orange, and a number of other S2 mutations in red. Moving on to 501YV2, in other words, the South African variant, you can see here that there are a number of mutations in common, for example, the 501Y. And one thing I haven't mentioned is, of course, that the UK variant on the left, the V1, has now been shown to be developing a cluster of infections containing the E484K mutation. Moving on to the right-hand side, you've got 501YV3, in other words, the Brazil origin variant. And you can see there are a number of different mutations in addition to 501 and 417 mutations. For example, L18F, and you can see a number of others there in the diagram spread throughout S1 and S2. So the next question is, why have these variants why have they arisen? So here is a case that we recently published of an individual treated for chronic COVID-19 infection spanning 4 months, which unfortunately resulted in death. The individual had an underlying lymphoma and was admitted to hospital. And you can see in this figure on the left that the CT values from nose and throat swabs was consistently elevated. And you can see the clinical course there with the patient being admitted with breathlessness and cough, requiring CPAP or positive airways pressure, and then eventually intensive care unit, and then intubation, but unfortunately progressive disease and death. During that admission, there were a number of treatments administered, including remdesivir, but also 3 units of convalescent plasma. And on the right here, you can see the variant frequencies in this individual between days 82 and 100 of the illness. And you can see big fluctuations in virus populations, almost looking like there are competing virus quasi-species. But in particular, we documented the real-time emergence of the delta 6970 mutation in real time, suggesting that this is a mutation that can emerge during chronic infection, consistent with the fact that we're seeing this as well as many other mutations arising in the variants that I've just shown you. So what are the implications of all of these variants for diagnostics? Well, for the 501YV1, we have undertaken in the UK a number of tests using the standard platforms, including, for example, the Panther setup, and there doesn't seem to be a significant change in the diagnostic performance of our laboratory tests. For the 501 V2 in South Africa, we can see that a number of platforms have been tested, including the Abbott M2000, Roche 6800, and Cgene CFX, as well as the Gene Expert, and these all show a maintained performance against the circulating variant in South Africa, so that's reassuring. As yet, I'm not aware of any data for the Brazilian variant 501YV3 on diagnostic nucleic acid testing performance. Here are some tests that may be affected based on the primer designs. The first is the Acula SARS-CoV-2 test by Mesa Biotech, the linear COVID-19 assay by Acula, and as I said, these may be affected because of S-gene targets. And this is likely due to S-gene changes in the B117 variant in the UK, also known as the 501YV1 variant. But the interesting thing is that we actually gained a diagnostic test in some regards by the emergence of these new variants. And this is because of that deletion at 6970 and spike that I talked about earlier. The phenomenon of S gene target failure in the context of B117 was one of the clues that people had in the UK that there was something different and a different strain emerging in the UK. We used the Thermo Fisher TaqPath testing platform in many of the centralized laboratories that have been testing community specimens for SARS-CoV-2 in nasal swabs. This test uses 3 gene targets. One is in the S gene, and this covers the 6970 deletion region. The other is in the N or nuclear capsid, and one in ORF1ab. As I said, it's commonly used in community testing. And when they retrospectively looked at over 31,000 samples from the community and looked at the S gene target failure status, they realized that nearly all of the Delta 6970 sequences were cases of S gene target failure after sequencing, compared to very few sequences which had S gene target failure in the absence of deletion. So this suggests to us that there are a number of, that the S gene target failure was due to the deletion 6970. This graph shows you what was happening over time in the proportion of tests that showed S dropout because of that 6970 deletion. And that is shown in black. You can see that the proportion of sequences shown to be B117 mirrors this beautifully in dashed red line. And the other 6970 deletion lineages, which are present in the UK, for example, the 439N439K plus 6970, had remained at relatively stable proportions during that time and even falling off slightly. So you can see a very nice correlation between the emergence of B117 or the 501YV1 variant in the UK and the S gene dropout signal. So looking more closely at the UK variant, here you can see the nucleotide and amino acid changes spread across the virus, in ORF1ab, in spike, there are 8 mutations. There's also, there are also mutations in ORF8, including a stop codon, and there are changes in the nuclear capsid. This variant is now present in more than 80 countries, as many of you know, and we know that it likely has a transmission advantage and potentially increased mortality, although those data remain to be verified. We have done some work on whether this new variant is going to be susceptible to vaccine sera generated by the Pfizer vaccine or the BioNTech vaccine. And we can see here that the amount of serum required for neutralization of pseudotyped virus is considerably higher for the B117 variant. And we found a fold change around between 2 and 3 for the B117 variant relative to wild type. This appears relatively modest, but this is a single round assay, and it's likely to be much greater when you look at multiple rounds of infection. We've also tested a number of convalescent sera, and there is variable response. This diagram here shows you a representative example of somebody who has a significant fold change, and the B117 is less well neutralized by this patient's sera as compared to wild type in blue. So going back to the 6970 deletion, of course, the B117 is one virus that contains this. On the top left, you can see where this deletion is. It's there in blue on an exposed loop that you can see, and you can see where it is in relative to the 4A8 epitope in purple. On the bottom shows you what happens when the 6970 deletion takes place. You can see in green, this is the post-deletion structure, and in blue is the pre-deletion structure. So there is a conformational change that's predicted, but this hasn't been proven through structural studies yet. And in the middle, you can see now the phylogenies of 6970 deletion containing viruses. In pink at the bottom, you can see the very large cluster of B117 containing viruses, and in the gray bars show you the fact that this has a 6970 as well as a 501Y mutation. If you move up that tree, you can see just above the pink is a group of viruses that has 501Y in the absence of the 6970. And further up, you can start seeing viruses that have the 453 and 6970. Those are from Denmark, as you can see in green, and we know that's the mink-related lineage. Interestingly, the 6970 deletion came after the 453 was acquired. As we go up, you can see the B1.351, which is a 501Y containing lineage. Of course, this is the South African variant. And then further upstream, you can see the 439K containing viruses that emerged initially in Scotland on their own at the top of the tree. And then you can see further down that they have acquired a 6970 deletion later on, and that now is dominating the 439 lineage. So this is just showing you that 6970 deletions have come up independently and in combination with other receptor binding domain mutations such as 439, 453, and 501. So this is an important deletion to consider. But we should be cautious against assuming that all S gene target failures are equal to B117. Here's some data from the Czech Republic and Slovenia, recently pre-printed, showing you that the B117 has similar viral loads to a lineage that contains N439K and the 6970 deletion that I showed you earlier that arose in Scotland, we think. Certainly the 439 arose in Scotland. Here is a phylogenetic tree on the right showing you the acquisition of 439 in the United Kingdom, and then the deletion 6970, which came after that. And of course, so this is an example of why you cannot use the S gene target failure in the TACPath assay as a proxy marker for B117. You need to do sequencing validation to understand what the proportions of different viruses are in your country or location. So it can be used as a surveillance tool, but it must be backed up by sequencing as well. Here's another case as to why you can't use the S gene target failure as a proxy for B117. This B1.375 lineage in the United States was recently described as well. And this is a lineage with only 6970 and a few other mutations. But again, the only spike mutation is Delta 6970. It is not a B117 lineage. What about lateral flow antigen tests? Well, the ANOVA, SureScreen, Abbott PanBio, Roche Biosensor, and Fortress antigen tests have been verified by Public Health England on the UK variant, and the performance is not affected by the new variant, which is reassuring. And this is because most of these tests are looking at the C terminus of the N gene. We don't have any data on South African variants yet, and that it needs to be done in addition to the 501YV3 variant. What about rapid nucleic acid testing platforms? The Samba2 platform that we validated last year appears not to be affected. This is a test that gives you a turnaround time of 1.5 hours. Unfortunately, it only does one sample at a time, but multiple machines can obviously increase your throughput. This test uses the E gene and the ORF1A, and therefore is unaffected by the B117 variant. What about antibody testing? Well, we showed last year that point-of-care rapid antibody kits, in particular two, the SureScreen and the Prometheus tests, were not affected by the D614G mutation. As you can see here, there are a number of our sequences in the panel were G at the 614 position, and this is middle of last year, but we did have some Ds at that position. And if you look on the right-hand side, you can see the results from D614G containing virus sera of patients who had been infected with those viruses and recovered. You can see that there's a very nice correlation between the intensity of those bands in the POC testing kit and the intensity over time. So that's an example of how a mutation in spike did not affect the rapid tests. We still haven't done those assessments for the B117 variant, but those are ongoing. What about lab antibody testing? Of course, well, S versus N-based tests may give different results. There's very little data on these, but we do urgently need to do these assessments because going forward, we will need to do accurate serological tests on populations in order to be able to track infection or past infection in those individuals and potentially try to differentiate it from vaccinated individuals. So in discussion, in conclusion, I have shown you that the new variant can be detected through S gene target failure in nucleic acid testing. However, we need to be aware that there are other strains with the 6970 deletion, for example, N439K circulating variants. We think that some other nucleic acid testing platforms may be affected, but more needs to be done. There is very little data on South African Brazilian variants or 501Y V2 and V3 variants. and antibody tests need urgent further evaluation. So there is a real need here to improve the amount of information we have. I'd just like to end by acknowledging the individuals on this slide for all their hard work. Thank you very much.
Thank you very much for all the speakers tonight who gave wonderful talks. And we have time now for a roundtable, and we have some questions about the audience. We have many questions about, of course, the variants, and I will ask some questions to David Eyre and Ravi Gupta about the variants. And there was a question about the possibility of reinfection with the different variants, and also for the diagnostics. I have a question about the interest of performing rapid screening of the variants, for example, with a rapid PCR test, for the use of monoclonal antibodies in the prevention of severe disease in patients. So what could you comment about that?
So if I pick up on the first point, which was around, can we say anything about reinfection with variants? The simple answer is, as of today, we're still looking at it. Maybe it's more difficult now to completely tease apart what's happening, because you have to think about who's been vaccinated, who hasn't, of the people who've been vaccinated, who actually had prior antibodies and who didn't. So you've multiple different groups to think about, and then you've also got different vaccines being used. And so there'll probably need to be an effort of pooling of data across multiple studies to really understand some of these questions. And the second point, which Ravi's made very nicely, is around sort of ascertainment of variants, and that it's not sufficient just to say we had S gene dropout. Actually, we may well need studies where sequencing's been done of PCR positive samples to understand the level of protection against different variants.
Just to chime in for a second, based on my understanding of the Novavax data from their experience in South Africa, around a third of the participants had evidence at entry of prior infection, and a third of the people who became infected in the placebo group had evidence of prior infection and were then subsequently reinfected by the new South African variant. Is that right, Larry?
Yeah. Yeah, I mean, I think the South African variant is a true immune escape variant that, is creating symptomatic disease. What we don't have really, and it is important and may differ in Novavax because it doesn't have a CD8 T cell response, versus where we saw something with J&J, where we actually saw protection with lower antibody. So we need to know if reinfection, especially with the South African variant, still could cause severe disease. And to some extent that'll be comforting to know that. And then we have to ask, how does that then relate to vaccination strategies, et cetera. So important piece of information here.
Yeah. There is a paper in Clinical Infectious Disease very recently on the case of French patients reinfected with a South African variant with a severe disease.
Yeah, there's one case. So again, we need the numerator and denominator, and
of course.
Unfortunately, South African hospitals were overwhelmed during this second wave of the epidemic, but is the issue of how many of those people in hospital and got hospitalized on oxygen really were seropositive before the acquisition, which would be really not good news for us, versus that there was just an increasing susceptible population because of the 501Y mutation, which is, of course, definitely increasing transmissibility and maybe have some evidence of increased duration of viral shedding as a sort of a surrogate correlate of that.
Can I come in just to clarify one point about the 501? There's a lot of people are saying it's the 501 that's increasing transmissibility. There really isn't a good rationale for saying that. It's associated with viruses that are appearing to transmit. We can see in single run infections it actually incurs quite a big defect. Yes, it does increase ACE2 binding. That may be detrimental, so I just want, a lot of people are saying it right now, so I want to kind of just put a break on that sort of theory, because it just runs away and everybody's just taking it as fact now. We really need to do more work on what the exact determinants are for transmissibility and infectivity, I think. But on the case of the 480, the next question, which was about detecting variants in people receiving monoclonals, I mean, that's a really interesting thing. I mean, yes, rapid tests would be great. But we kind of know some of the mutations we'd look for, I guess. But the problem is that we'd probably very quickly be redesigning that, because we'd find mutations that we hadn't thought about, coming on top of different flavors of mutations in the RBD. So yes, I mean, yes, ideally, yes, we need point of care resistance tests, essentially, which we've been through this with HIV, and I think that we should really try and apply as much of our understanding of that, of where we got to and what the barriers were to actually, we never really implemented point of care resistance testing. We should ask ourselves why, and whether this is a different enough scenario where we think they are going to work. But I really think there should be a much bigger debate around it. I agree with Anne-Geneviève.
Ravi, do you think there's been any evidence that the use of convalescent plasma has driven the emergence of our variants?
There's no direct evidence, Dan, and I think that I'm sure it's just one of many things that could lead to new variants. We saw that case published in Cell where the patient was asymptomatic, developed multiple deletions over time, and wasn't treated with CEPI as far as I can remember. And then you have other cases that were treated. And of course, we have so few treatments, then of course, chronic infection equals panic, equals monoclonals, equals convalescent plasma. So it's going to be really hard to tease apart exactly what the CEPI's role in it, without a prospective study, I think.
Okay, thank you. We had a question about the vaccine and the development of vaccine for the children, with a question about are children to be given the same dose of vaccine as adults, and the same 1 dose or 2 doses? What are the plan?
Well, the plans differ a little bit by company, and in the teenagers, so far, no one's made a dose adjustment. In the 5 to 12-year-old ranges, there are starting to be some studies of dose adjustments with the RNA vaccines, and I'm not sure I'm not really quite sure of J&J's plan of as far as any dose adjustment with the Ad26. And I think the protein vaccines, at least the Novavax, is already at 5 micrograms. I think they plan on sort of keeping that dose. Most of I hear at least down to 5-year-olds. So it is, our Food and Drug Administration has been wanting a significant safety database for kids. And so I don't think our country is going to get done with these studies till May or June.
To follow up on that, there were a number of questions that relate to what are the correlates of protection, and in a pediatric population where the rates of symptomatic infection are so low, could you ever do a vaccine study comparable to what we've seen done in adults, and then where do the correlates come in and what would they be?
Those are all good questions. I think there's sort of universal acceptance that this is going to be a bridging antibody immunogenicity, sort of whatever the mechanism is that we have in adults, this vaccine will do this in kids. I think the J&J data versus the mRNA data are showing us, I think already, that there are multiple mechanisms of correlate, of going to be multiple correlates of protection, that even if we get a neutralizing antibody correlate with the RNA, is that really a mechanistic correlate? Because the neutralizing antibodies are in OWS labs with the J&J lab vaccine, 1 dose is really incredibly low and very hard to explain that degree of great, the important thing of protection against severe disease in the 80s
whether it's South Africa, Brazil, South Africa with the B135 variant and the P2 variant in Brazil, and no variants in the United States as the D2G variant, all having pretty similar severe disease with very low antibody titers, all suggest that there is an adaptive immune response here that's controlling severe disease. So, so even if we come out of a correlate, we don't, the RNA data from Moderna will sort of appear at the end of March, and it's certainly, all of it is sera. So if there is a correlate, it's going to be an antibody correlate. It's hard to think that there's going to be an antibody correlate with the J&J vaccine.
Okay.
That's quite interesting, given the primate data, isn't it? So, sorry, I've missed a couple of the talks today, but certainly the Baruch study on the J&J vaccine in the monkeys suggested that neutralizing antibodies was the only, well, was stronger, more strongly correlated than T-cell responses.
Yeah, it is monkeys, number one, and I'll also say that the assays, when you level the assays in a similar playing field, you see differences, and so I'll just say that that reading the literature, that there are differences in let's say the assays that have been validated for OWS, and so we may see some differences. So the data aren't totally out, but if you believe that the South African variant invariably is showing a 5-fold lowering of antibody titers as compared to, whether it's convalescent sera or you're super immunized with an RNA, it's hard to conceive that the antibody correlate in the J&J vaccine, that the antibody level of that single dose is enough to protect 85% against severe disease.
Yeah. Okay. Yes. So you're talking about severe disease rather than infection. Okay. So
well, even in infection, frankly, in my own opinion, it would be even infection. Okay. That but I'm just making the point that I think that the correlates of protection of disease, and whether that's going to be mild, moderate, or severe, is probably going to be multifactorial, and not so certain that it's going to be transferable cross-platform.
Can I ask a follow-up question? I mean, just about, you're discussing neutralization levels in the blood, which is a really interesting area. A lot of studies use quite conservative cutoffs, like 1 in 40 for neutralization of 50%. We go down to 1 in 10, and that's where we can see differences, but there's more noise. So, do you have an opinion on on the differing neutralization thresholds and how they affect the study?
No, because as you said, you get down to 1 to 10, there's a lot of noise, and the input viruses enormously influences the, every virus that ever is done with a neutralization assay. The input virus markedly influences the output number. So,
So I think you made an important point there as well about the 5-fold sort of average effect of the South African variant, let's say, in terms of vaccine sera. And people have been debating, what sort of magnitude is important. And I think you're right. I think if you hit 5x, that's pretty significant. Whereas a lot of people were waiting for, fold changes in excess of 10x to be impressed. But I think, maybe you agree, it'd be good to get a consensus on, to say, is 5x a sort of area where, where we start worrying?
Let me bring Jakob and Sanjat into this conversation as well here. One question is, are there differences in antibody responses to the N protein in severe versus mild disease? And a corollary to that question would be, what about antibody responses to other components beyond the spike in N proteins?
Well, those are all good questions. Natural history data really shows that people who are hospitalized and have, more symptomatic disease have certainly higher antibody titers than those who have mild disease. And there's just lots of cohort studies that show that in natural history. If the question was being asked, do we have a correlate as to a threshold as to who got a mild or moderate severe disease in any of the RNA studies? No, we don't at the moment. And that's not that it's just because that's what's being looked at in the correlates of protection data that are being, collated. And I think we're just going to see those analysis at the end of March. for the Moderna study, and I can't say much about Pfizer. So those are two questions I remember. If there are more, then I need to repeat them, Dan.
Sanjat, could you comment on that, please, on the level of the protection between vaccinated people and COVID-19 natural infection?
Right. So if I understand the question correctly, it's whether our diagnostics, our clinical diagnostics, can actually differentiate between people with immunity versus natural infection. And it really depends on the target that you use. So as mentioned by multiple speakers here, many of our current antibody assays target the N protein, which is not a target for the vaccine. So that's an easy way to differentiate. If you have positive antinucleocapsid antibodies, then you've been previously infected. As far as the levels, though, that's a much more challenging question. And that's the one that I think is getting at the plethora of assays that we use. They all use different platforms and ways of reporting, and they don't correlate with one another. So you have to go to universal standard, which is plaque reduction neutralization titers. And unless those are done exactly the same, it's really hard to know. So I think the point I was making is that every clinical lab kind of has to do their own internal work to correlate the functional response of the antibodies detected by their assays in plaque reduction assays. And so it's quite variable. And then with the question of the variance, it means you have to continually update your functional analyses to stay with what's going on in the current circulation around you.
And Jakob, is there a CT cutoff that will help us distinguish true infection from just either persistence of nucleic acid or exposure where you have some virus but are not truly infected? And then what if the vaccines fail to prevent transmission? Where will that leave us as a society in terms of getting back to normal?
So the PCR, I think, it's a difficult test, in particular in clinical trials, simply because you have to repeat it, I guess, on a weekly basis, and even a 99%, as I said in my presentation, 99% sensitivity, specificity would, if you did this, for example, in a large trial with 40,000 subjects on a weekly basis, would generate a lot of false positive tests. I think the point of care tests are more interesting. I know that they are less sensitive and maybe less specific, but even if they are false negative, or if they are false negative, they may truly indicate that this person may not be infective. That might be false negative, and that person still may be infected individually. But if this is not, if the antigen load is not enough to turn a test positive, it's still a good indicator, at least in a clinical trial, to demonstrate infectivity of this particular person. The question moving forward and how much emphasis we should put on infection and transmission, we are debating this in CEPI and within the COVAX initiative intensely at the moment. I mean, we are very happy to see this high point estimate for vaccine efficacy that has been generated by the mRNA vaccines last year. I have to say that they were fortunate to be tested in a different environment, in a perfect environment, in the sense that we had a good match between the vaccine strain and the circulating strain back then. We have seen from data in South Africa that an endpoint PCR confirmed COVID of any severity did work very well for mRNA vaccines and worked very well in that environment with the perfect match. But we have seen from South Africa that if you bring in new variants, it is more difficult to prevent any severity. And this is a little bit what we have seen in the influenza world as well. We have been using the same H1N1, or more or less the same H1N1 strain since 2009, and we have not prevented with seasonal influenza vaccinations transmission so far. So I think the focus moving forward with vaccines and also accounting for new variants, and that was already addressed in this discussion, is really primarily to keep people out of hospital, to prevent severe disease, and to prevent public health systems from overwhelming. It would be nice to have, in addition to that, an effect on transmission, and some data from Israel seem to be interesting and promising. but maybe this is not and should not and cannot be our primary focus, at least for testing vaccine efficacy in clinical trials.
Could I come in there just about the first point that you were talking about? So the relationship between CT and infectivity. So what we've been able to do, taking some of the test and trace data from the UK nationally, is to look at contacts of people and look at, given the CT value in the index case, what's the proportion of contacts that go on to test positive? And what we find there is, yes, there is a relationship between CT. And what we can then do is pair that up with data on how the lateral flow tests are sensitive across different ranges of ST, and bring that together to show that although lateral flow tests might be imperfectly sensitive, they might pick up as much as 90% of cases that go on to transmit on to other cases, showing that they may well have some utility.
Yes, we have the same reflection in France. We all agree on the CT value at 33 to as a threshold for less transmission.
Yeah, I think it's definitely helpful to think of sort of upper limits, but it's also what we find is that there's really an almost linear relationship across a range of CT values. So as you get lower and lower viral loads, the chance of transmission gets less, but the same holds that the person with a CT value of 10 is more infectious than this person with a CT value of 20, for example.
One of the questions that's been posed, which is I'm sure going to generate some controversy, is whether and when you imagine vaccination might become mandatory. And it'd be interesting to get different people's perspective on this.
Maybe start, sorry, so before we have further evidence, I know this is also taking place in my home country, Germany, here at the moment. Before we have any evidence on the duration of protection, before we really understand what this means about transmission and infection, I don't really see that vaccination is a good replacement for non-pharmaceutical interventions like face masks and so on. And then secondly, we in Germany were really quite tough with data protection. So what is the practical approach? Will you really, when you go into a theater, show vaccination certificates, and is this really reliable evidence? We have different vaccines out there. I see this quite difficult to really translate this into an alternative to kind of, or as a mean to decide about lockdowns and other means at this point in time, at least. Over.
Yeah, it's a very complicated question, and I think Jakob answered a nice job on that. I think to me it's a moot point because we are in vaccine scarcity, and then comes the issue of at what point in time there's U.S. scarcity, there's European scarcity, there's global scarcity, and so at what point do you do that? If we start seeing nosocomial transmission and other kinds of things, hospital workers and protecting nursing homes, I can sort of see some element in those high-risk situations, and especially employees as a risk factor, that we may do some selective kinds of vaccinations in high-risk situations. That to me makes rational sense. Coercion is usually not a good way to get things to happen in any large population basis. So I think the idea has limited value at the moment, really, in being a practical debate.
Maybe a last comment on the potential interest on the mucosal vaccines to try to prevent the transmission. Any?
Well, hope springs eternal. The scientific community, has to come up with a good mucosal vaccine, and it'll have to go through efficacy testing, and someone will have to fund it, and want to do it. So, okay, someone champion it and take that P and roll it up the hill.
Okay, so I think we had a wonderful roundtable discussion. I would like to thank all the attendees for their presence at this session, all the speakers for their excellent presentation, and then for the co-moderation and all the sponsors. So there will be a break of 15 minutes, and then there will be the next session at 8:30 CIT on not winter has arrived, but vaccine has arrived.